All right. So just let me know if you're able to see the full presentation. Heba, Mariam,
Yeah,
Hala.
I'm
Yeah,
able to see. Yeah, yeah.
All right.
It's
yes,
fully
we
So,
can.
visible.
all right. So I'm going to start now. Good evening, everyone. I'm Dr. Prabhat Nangia. I had taken the cornea class about 10 days back. So I'm primarily a cornea surgeon by training, but I also practice strabismus at this point in time. And as he mentioned, I had appeared for the FICO in pediatric ophthalmology and strabismus recently. So I'll start off with a few questions about the basics. I'd like any of you to please volunteer. As I said, I'm not able to see the participant list. Could somebody volunteer for the first question? What is the cover test, uncover test, and alternate cover test? How do you perform them? And how do you interpret? What is the purpose of each test? Hala, maybe you could take this.
I'm driving, okay?
All right, I'm sorry. Maybe somebody else.
Yes, sir, I'll take it, Mariam Hussain.
Thank you. Thank you so much. Yeah, yeah. Go ahead.
Okay, so the cover test detects tropias, and
Right.
the uncover test is for phorias, and the alternate cover is for the total amount of squint, so phoria plus tropia.
Wonderful. So, how do you perform the cover test? How do you perform the uncover test? And how do you perform the alternate cover test?
Okay, so before doing the cover test, I'd like to have a gross idea of the patient's vision, whether they are at least counting fingers at 1 or 2 feet, so that I know that they're able to see something.
Hmm.
And I want to do Hirschberg before, so that if there is an obvious manifest squint, I want to start by covering the non-fixating eye first, the fixating eye first, so that I can see whether the non-fixating eye takes up fixation.
Yes. All right. All right. So, and the uncover test?
The uncover test, as the name suggests, the uncovering part is important. So when we uncover, we want to look at the eye which was just uncovered to see whether it deviated under the cover.
Yes. Right. So that's how it detects the 4 years. Wonderful. She has covered everything about this. So I hope that all of you can see me. I'll just demonstrate it for you. Just imagine that I'm looking at a target. This is the cover. This is the uncover. This is the cover. This is the uncover. All right. And then alternate cover. All right. So that's all that you need to do. If you get you're going to get a squint case in the exam. That much is certain. It may be a nerve palsy or it may be an ESO or an EXO. Those are the most likely ones, but of course they can keep the syndromic ones or the special ones as well. So this is where you make it or break it. If you do the cover test, the uncover test, and the alternate cover test properly for distance and for near, and you ask the patient whether he or she has glasses, and if so, to put on those glasses, then the possibility that you will clear that station increases quite a bit. Does anybody else want to take up Herring's law and Sherrington's law? Hello?
Yes, sir. Sir, I will take it. My name is Dr. Asma Azhar.
Wonderful. Please go ahead.
Yeah. So hearing law is basically the hearing law is the hearing law of equal innovation. That is, if the nerve signal is going to like medial rectus of the right eye, then the same signal it goes to the its yoke muscle. That will be the lateral rectus of the other eye.
Okay, perfect. So they will work in tandem to cause the uh, gaze, to stimulate the gaze, right?
Synergist.
Yeah. Synergist action. Wonderful. What about Sherrington's law of
Yeah.
reciprocal inhibition?
The Sherrington's law of reciprocal innovation. It might to the that if innovation is going to like medial rectus of one eye, the decreased stimulus is being sent to the its antagonist muscle in the same eye,
Right.
like the lateral rectus eye.
Wonderful. So that's how the ductions happen. Good. Great. Great.
Yeah.
So
Yeah.
I'm not going to go through the notes on cover test and uncover test because she's covered everything. So the Herring's law states that for a binocular movement, that is a version, the corresponding yoke muscles receive equal and simultaneous innervation. The example that she has shared is spot on. The Sherrington's law states that for any binocular movement, the direct antagonist receives an equal and simultaneous inhibition of its innervation. So, for instance, if the medial rectus of the right eye is stimulated, um, then the lateral rectus of the right eye will be inhibited, and that is how the duction will happen. Adduction will happen for the right eye. So, what is AC by A ratio, and how do you measure it? Volunteer, please.
The accommodation
Yes, sir.
convergence ratio, sir.
Who is this? Hello, who is this?
This is Nejla,
Hello.
Dr. Nejla.
Okay, please go ahead. Please go ahead.
So for how much convergence is happening for every diopter for accommodation? That is what it means. So the normal value is 3 to 5. There are
Prism
many
diopter
methods,
per diopter. Yes.
3 to 5 diopter.
3
There
to
are
5
many
prism,
methods
no,
to
no, 3 to 5
so
prism diopters per diopter. Because
prism
convergence is
diopter
measured
per
in
diopter.
prism diopters, and accommodation, that is A component of AC by A, the denominator is measured in diopters.
Diopter. Okay.
Right? So 3 to 5 is correct. Do you know the methods of measurement, and can you describe any
Uh,
method?
there are 3 methods,
Right.
heterophoria method and gradient method.
Wonderful.
And one more is from synoptophore, I think.
Yeah.
The in heterophoria method, the interpupillary distance also come into the action,
Correct.
and we have to measure the deviation in the distance and in the
Near.
near.
Yes.
Yes.
So the
So from that, near minus distance divided by 3, that is plus IPD. That is what heterophoria method. In gradient method, either we put a +3 diopter in front of the patient and we measure uh,
distance.
deviation in distance, and
Yes.
then we deviation in the near. Then we remove the glass. Then we measure the distance. And there is another method we can put -3 also. Here IPD won't be in the equation.
Correct.
The deviation in the distance near minus distance divided by 3. That is the value.
So most of it is right, but I believe that the plus lens in gradient is used for distance. What that means is that you look at distance and you first measure the deviation, and then you put the plus, and again you're looking at distance only and you measure the deviation. So that is, you are simulating near while looking at distance. It's something like that.
Yes,
And
yes,
for
sir.
near, then you measure first without the glass and then put a -3 and then measure again at near only.
Okay.
That is how it
Yes,
is
sir.
done.
Yeah, that part I have messed up
Yeah, yeah.
when
So
I told. Yeah.
better that you read that, and I would just avoid the discussion about the gradient method because it's very complex. Plus, because
Okay.
it does not include the IPD, the general belief is that the heterophoria is a very reliable method. So the heterophoria you've described correctly. So just go ahead with that description if asked in the exam.
Okay, sir.
All right. So this is a case scenario. 7 months old male infant brought by the parents who report constant inward deviation of both eyes since 3 months. You examine and find cross fixation, near normal visual acuity for age, 40 prism diopter base out deviation, apparent limitation of lateral gaze, which improves when ductions alone are checked, and mild hyperopia, that is plus 0.5 diopter sphere in both eyes. What is the likely diagnosis?
Yes, sir. I'm Dr. Hiba.
Yes, please.
It is essential infantile zootropia.
Okay, wonderful. Essentially infantile?
Esotropia.
Wonderful, wonderful. Excellent. Great. So infantile esotropia is normally a large angle esotropia, usually more than 30 prism diopters. It is characterized by free alternation or cross fixation. So then you're looking at the right side with your left eye and the left side with your right eye. No significant refractive error. Confirmed by the age of 4 to 6 months. Less than 4 months is where we really cannot be sure whether the the infant has any sort of deviation. So we do not comment on it. So, but between 4 and 6 months, it normally gets confirmed. Associated findings, common findings are inferior oblique overaction, dissociated vertical deviation, and manifest latent nystagmus. So what is this test? And can somebody describe how it is performed?
This is a test for stereopsis. It
Yes.
is a litmus fly test.
So in this actually,
This glass is
you're not seeing
polarized
the fly.
glass.
Yeah. So do you want to?
What?
I'm saying you're not seeing the fly here at all. So it can't actually be the titmus fly. It may be there on another page or in another book, but here it is not there. So we can't call it the titmus fly.
Litmus test. Okay.
So it's not. This is not
And
the.
this is
Yeah.
polarized.
So, do you want to change the answer? Is what I'm trying to ask you.
Mhm. No, I don't know.
Okay. So it's called the random dot stereo. Yes. Who's this? Okay. So it's called the random dot stereo test. When you look at the area, there are animals on the below part of the right hand side, and just above that, there are a few uh, circles. All right. So it uses a pattern known as the Joule's random dot background to mask the monoocular cues. And it is characterized by the animal test, that is the lower side on the right, lower part on the right side, that is the animals, and the upper part is the words circles. So it gives a 3D appearance when you use the Polaroid glasses to look at it. So it used to measure stereopsis for near. All right. So the circles test, the word circles test, can measure between 400 to 20 arc seconds of stereopsis. The lower the value, the better is the stereopsis. So somebody with perfect alignment from childhood will normally have about 40 arc seconds of stereopsis. And those who have a decompensated exophoria, that is, they have alternating exotropia, that is, there is no longer a phase of phoria, they often have stereopsis less than 400 arc seconds. So what is this image, and can somebody describe this, please?
Yes, sir. Can I?
Please go ahead. Please go
But
ahead.
I am again for the third time. Okay. This is a photo for 9 cardinal position
Yes,
of a male patient. Showing in primary position, there is there is hypotropia in the left eye.
correct.
Um, in the version, in superior version, there is no elevation of the limited elevation of the left eye.
Okay.
No problem in in depression in dextro version. And in Levo version, there is also limited elevation. So there is limited elevation in all gazes from dextro version to Levo version,
Okay.
and even in up and down and up gaze also, straight up gaze. So I can diagnose that is elevation monodeficit syndrome.
Okay. Okay. Monocular elevation deficit. Yes. Very good. So
Monocular elevation deficit.
yes.
This
Yes.
is one of the CCDD syndrome, cranial cranial
Congenital
disinnervation disorder,
disinnervation disorder.
congenital cranial.
Right.
Yes.
So she's right. This is monocular elevation deficit. I'll just elaborate on the description once. So I would call this a 9-gaze photograph, showing hypotropia in the primary gaze, hypotropia of the left eye in primary gaze, dextro version and levo version. Limitation of elevation. Never use the word restriction. She didn't use it, but I'm just focusing on it because this is important. Limitation of elevation in in sursum version, that is elevation, dextro elevation and levo elevation. And dextro depression and levo depression are within normal limits. So that way you have described all 9 cases, which she has anyways done quite well. So do you know the types of monocular elevation deficit? And how would you like to treat this patient? The patient he was 17 years old and has a vision of 9 in the right eye and counting fingers at 2 meters in the left eye. Could you continue if you would like you can continue, doctor.
Yes, if Dr. Heba can't answer,
Yes, please go ahead. Yeah.
okay. There are three types of monocular elevation deficit.
Hmm.
Type 1, the patient is also in the primary position. Type 2, there is limited adduction. Type 3, there is a limited adduction and downshoot in downshoot and over and downshoot over adduction.
So not exactly. The types that you have described are sounding a little bit like Duane's retraction syndrome. So I'll tell you the types of MED. The first one is the restrictive one. That is, there is inferior rectus restriction with a force duction test positive for elevation. So when you grasp the eye at the 3 and 9 o'clock limbus on table and you rotate the eye upwards, right? When you're doing the FDT on table, you will not be able to rotate. You will not be able to rotate the eye fully. Okay, that is type 1. Type 2 is paresis of the superior rectus. So there is no inferior rectus restriction. It is only a weak superior rectus. Therefore, the force duction test in elevation, where you're testing the restriction of the inferior rectus, will be negative. And type 3 is a combination of both. Now, when you have a positive FDT, that is a tight inferior rectus, you need to first tackle that. So you need to first recess the inferior rectus. So we normally recess it by about 5 millimeters to really make it loose. It is also important to do the FDT immediately after you have reattached the inferior rectus to the globe to ensure that there is no remaining restriction. This can be subsequently followed 3 to 6 months later by what is known as a NAPS procedure, where both the horizontal and the medial recti are cut from their insertions and transposition closer to the superior rectus insertion, which I will show you schematically in the next slide. If the FDT is negative, that is either it is a supranuclear MED or it is a superior rectus palsy, you may directly go ahead with a NAPS procedure. Now, this is what I was talking about. So the NAPS procedure, the figures on the left side are the NAPS procedure, showing vertical transposition of the medial and lateral recti close to the insertion of the superior rectus. A modified NAPS procedure shows vertical transposition of the superior half of the medial and lateral recti. All right. We, however, prefer to do what is known as a modified Nishida's procedure. So you use a non-absorbable suture 10 mm behind the insertion of the medial and lateral rectus. So first you do one muscle, let us say you do the lateral rectus, you pass a non-absorbable suture through the superior 1/3 of the lateral rectus, 10 mm behind the insertion, and then you use the same suture and pass it through the sclera close to the superior rectus insertion, and you tie the suture. So that portion of the muscle is stretched superiorly, as you can see in the image on the right side, and therefore the vector force is transmitted superiorly also. So even in the primary position, while remaining attached to the globe, the lateral and the medial rectus will also have a secondary function of elevation. So this also gives satisfactory outcome, and in addition it has the advantage that you don't have to cut the muscle at its insertion, and therefore you do not risk anterior segment ischemia. And once you have taken care of the elevation component, most or all of these patients have true ptosis. Some of them may have pseudotosis, but a lot of them will also have true ptosis, which will only be revealed after you bring the eye to the primary position. Then whatever ptosis remains needs to be operated accordingly with a frontalis sling surgery. So how is this force duction test done? It is done differently on the slit lamp and differently on the operating table. And how do you interpret it? Do I have a volunteer, please?
Doc. I am Dr. Shalin. I'm a
Hi,
volunteer.
please go ahead.
For the force duction test, you can either use a topical anesthetic
Very good.
and a forceps
Yeah.
to hold the conjunctiva in the direction of, pull the conjunctiva in the direction of limitation to see if there is a restriction on movement. Or you can use a suction device as well over the cornea
Suction.
and
Okay.
manipulate the eye
Okay.
in the direction of limitation.
Okay. Is there another step to that? So you've used a forceps, and what happens after that? You've held the conjunctiva with a forceps, and do you move the eye, or the patient moves the eye, or both?
I believe I move the eye. I ask the patient to relax
Okay.
while I move the eye.
All right. So I'll make a few changes to your answer. So you grasp the limbal conjunctiva and rotate the eye fully in the direction of limited duction. So let us say we come back to the case of monocular elevation deficit. Then I would grasp the eye. Ideally, if I could, I would put topical anesthesia, put a speculum, hold at 3 and 9 o'clock, and rotate upwards, which is what I discussed. So on the slit lamp, it will look a little bit like this. All right, because on the microscope, you will pull it towards you. On the slit lamp, you'll just go up like this. So you you grasp first, and then you ask the patient to rotate, so to speak. Patient will rotate the eye fully, and then you try to rotate beyond that. So you're holding, and you'll try to rotate beyond that. So if there is a restriction, that is, for example, thyroid eye disease or monocular elevation deficit, that will show a positive force duction test, which means that you will feel a tug. If it's just a palsy, paresis, paralysis, whatever, then there will be unrestricted movement for you when you are doing it. So you won't feel the tug. You won't feel the force from the restricted muscle. So again, let us say you look at a case of thyroid eye disease. You ask the patient to look up as much as he or she can, and then you hold, and then you try to go beyond that. If you don't feel any restriction, that is a negative FDT. If you feel a restriction, that there's something that's holding you back from going beyond that point, then that is a positive force duction test. And on the operating table, just before the surgery should be performed. So let us say that, again, we'll come back to the MED case, that you when you do the force duction test for the recti and the obliques, it differs a little bit, because the idea is to make the muscle taut. So the recti originate at the annulus of Zinn. So they originate posteriorly in the orbit and run forward. And the obliques, the inferior oblique actually originates in the anterior orbit and runs like this. And the superior oblique, while it originates behind, the functional origin is at the trochlea. So it runs like this from the trochlea backwards. Therefore, you need to make the muscle taut. So when you are doing the FDT for the recti, you will pull the globe up and then check the movements. All right. And then hold at 12 and 6. Again, pull up and check for the medial and lateral rectus. When you're doing the FDT for the obliques, you're going to hold the globe and retropulse it, and then intort and extort. All right. So that will be different for the recti and the obliques on table. Can someone enumerate the steps of muscle recession?
Sir, can I ask a doubt?
Yeah, sure.
In the sit lamp also, you will use two forceps.
If I
The sit
can,
lamp
otherwise,
also.
the textbook mentions just one, but so you can say whatever is written in the book that you're reading.
Okay, sir.
Yeah. So I don't know what you're reading currently, but whatever is written in the book that you can mention, not a problem. It's easier. It's easier when you use two forceps. Just that you may lose control of the joystick, but it's just easier.
Yes. Mm.
Can somebody take this question? Enumerate the steps of muscle recession.
Yes, sir.
Please go ahead. Please go ahead.
Uh, if we are doing for the like medial rectus cessation,
Right.
first we pass the corneal or limbal suture to hold or to drag the cornea on the globe on the one side, and then we do a small conjunctival peritomy, vertical along the limbus. I don't remember the landmarks, the centimeters, but just
Sorry, what was the
side of.
last part? What was the last part that you mentioned?
I don't remember the how much millimeters away from we should do peritomy, but we do peritomy along the limbus,
So I'll tell
and
you
then
that.
we identify the
You may
muscle with.
either, one second, let's clear this out for the other people. So either you may use what is known as a limbal incision or a fornix incision. So a limbal incision is performed at the limbus and a fornix incision is performed 8 mm away from the limbus. So both incisions you can use to open the conjunctiva or do the peritomy. And the rest of the steps are almost the same that you're about to mention. So it's not about the landmarks per se, it's just your approach. So for me, for example, on the medial side towards the medial rectus, I prefer to do a limbal approach. On the lateral side, I prefer to do a fornix approach. It's just a personal preference. So you can say whatever you do or whatever you think you would become comfortable doing if you're not actually practicing strabismus. So that's fine. Don't worry about it.
Okay, so
You can say that you open the conjunctiva at the limbus. Okay. So you conjunctiva you've opened. Now tenons is there. Will you open that?
Yes, sir.
Yes, exactly. Good. It was a trick question. Good. Go ahead.
And then, sir, we use the muscle hook to just we go back at the side of medial rectus muscle, and we'll drag the medial rectus from down, and we will pass suture just at the insertion. First
You
suture we
pass.
will pass
Again,
half this.
I'll make a small change here only. So first you
Yes,
use
sir.
a short muscle hook, such as a 1 graphis hook. All right. And you go just behind the insertion. All right. Just behind the insertion and pass the muscle hook underneath the muscle belly. Just
Yes, sir.
beyond the insertion, behind the insertion. All right. So now
Yes, sir.
you've got a short hook underneath the muscle belly. Then from the same space, you may pass a longer hook, the Jamison's hook. All right. Or the Green's hook. Then you may pass that and ensure that you've got the complete muscle belly. And that the end of the insertion is visible on both sides, superior and inferior. Okay?
Yes.
Next step, what you were mentioning with the suture.
Yes, sir. Sir, just at the insertion, just 1 millimeter away, we pass the suture. First, half thickness of the muscle, and then the full thickness, and we will tie the suture, and we will hold the muscle, and we will disinsert the muscle by holding the muscle with the sutures.
Yes.
And then we will measure that how much amount we do for the recession with the caliber, and then we will reinsert the muscle at the marking we used for the
very good.
And then we just tie the muscle with the sclera with the tight sutures, and then we will close the peritoneum with the conjunctiva.
So you've described it quite well. Couple of additions here. You must always mention which suture you're going to use. So it's a double-armed 6-0 polyglactin or vicryl. You may call it vicryl also, or you can call it polyglactin. All right. That is for the for suturing through the muscle. Okay. And that you will then also use when you've cut the insertion. After you've taken the suture through the muscle, you've cut the muscle at the insertion. You measure and you pass partial thickness through the sclera at the point that you have measured to recess the muscle as per the appropriate amount. So then where you have marked and where you pass your suture becomes the new insertion of the muscle. And then you tie off the ends of the suture and close the conjunctiva with 8-0 polyglactin or 8-0 vicryl, whatever. So if you describe it like that, it will be even better for you.
Yes, yes, I just forgot the sutures, but I just know the technique.
But it was good enough, quite good. Okay.
Thank you.
Yeah. Can someone describe this? It's not a typical exam case, but there is a typical finding. So, yeah.
I will try so.
Please, please.
This is a 9-gaze photo showing the eyes apparently straight in primary position. No limitation seen on levo or dextro vision or depression. In elevation, the right, there's limitation of upgaze in the left eye.
Limitation of upgaze in the left. Okay. Okay. So I'll make a few changes to your diagnosis. So unfortunately, I had taken this 9-gaze photograph, and I'm sorry to say that I did not use the flash, so we didn't get a good reflex. But when you look at the primary gaze closely, you will realize that the scleral show of the right eye inferiorly is a little bit more than the left eye.
It is
So
hypertropia.
she has hypertropia in the right eye. It's a very subtle finding in the primary gaze. I agree with you. But the more important findings are the other gazes. So you mentioned that there was that dextro and levo elevation are dextro aversion and levo version are normal. That's not exactly true. When you look at levo version, you see that the eye is elevating in levo version. All right.
Yes.
All right. Then when you go to elevation and dextro elevation, they are normal. But in levo elevation, the right eye is showing over elevation in adduction. Correct?
Yes.
And then in dextro depression and levo depression is normal.
Okay.
Okay. So this is a case of right hypertropia with inferior oblique overaction. All right. So it may or may not have been a fourth nerve palsy that has manifested like this. But what is certain is that she has right hypertropia and she has inferior oblique overaction, either because of fourth nerve palsy or because the inferior oblique overaction is so much that it is elevating the eye even in primary position. So now, how do you want to treat this patient? She has cosmetically disfiguring over elevation and adduction, and she has hypertropia in primary position. How do you want to treat this?
Okay. So I'd like to take a full history with respect to onset and course and duration of the symptoms that she's having. Any history of trauma, family history or drug use, any previous surgical interventions, and do a full examination of the anterior and posterior segments of the eye. We can have a period of observation to see if there's any improvement, followed by a inferior oblique myomectomy.
Okay. Okay. So, inferior oblique we don't really call it myomectomy, we call it myectomy, but also that inferior oblique myectomy is no longer the standard of care. So I would recommend that when you're speaking in the exam, you talk about inferior oblique recession.
Recession, okay.
So there are multiple procedures. This is a diagram from Dr. Pradeep Sharma's textbook that is very popular in India for strabismus. And having said that, if you look at figure A and figure B, so we know that the insertion of the inferior oblique is far behind the insertion of the lateral rectus, very, very close to the macula. So you disinsert it, all right? And when you resuture the disinserted inferior oblique, my mistake, inferior oblique, 6 mm inferior and 6 mm posterior to the insertion of the lateral rectus, that is known as Fink's recession. When you reinsert the disinserted inferior oblique, 2 mm lateral and 3 mm posterior to the inferior rectus, that is known as Park's recession. So you can take either of those names. I do the Park's method of inferior oblique recession, so I use that. All right. So I would have said that try not to say myectomy because it's not really considered the standard of care any longer. And we have to speak in terms of what is the standard of care.
Okay.
Okay. All right. There's also
Sure.
something known as an antero-positioning.
Okay, thank you.
Yeah, you're welcome. Well answered, well answered. Also something known as an antero-positioning that is used in cases of dissociated vertical deviation. What is this test, and can somebody describe it and try and make a diagnosis?
So this is Dr. Nejla. This is a Hess chart.
Right.
The right eye shows the restriction of movement in the lateral rectus direction, that is the abduction. And in the left eye, we can see overaction of medial rectus. And there is a overaction of the medial rectus in the right eye also. So it's probably a case of right LR palsy.
Wonderful. Wonderful. Absolutely fantastic. So she's really simplified it. And but what I'm going to use this, because this I believe is the simplest Hess chart that you can get, is that I'm going to try and teach you how, whoever of those who don't know how to interpret a Hess chart and really use tricks to just get to the diagnosis. So when you look at the right eye chart, all right, whenever it says green before right eye, it means that it's mapping the movements of the right eye. When you say green before left eye, it means it's mapping the movement of the left eye. Okay. It's not necessary that it'll, on top of that, it'll say left eye and right eye like I have said. It may just be that it's written green before left eye, green before right eye. Now, just remember that the smallest chart, the smaller chart is the eye with the palsy. And the direction of limited duction tells you which muscle has palsy. So from that, you will be able to tell the diagnosis like she has done. So here, the smaller chart is definitely the one on the right side. That is the right eye Hess chart. And the limited duction is the abduction. Therefore, it's a right eye lateral rectus palsy. Moving to the next. Can somebody try and attempt this, please? Not the same person, but somebody else.
Yes, sir.
Please go ahead.
Can I start? Okay. By inspection, there is a limitation in the field of the right eye. So this is the eye with the pathology. So I'll start interpretation with it. Looking for the center point of fixation, there is a slight hypertropia. And looking for the muscle, there is limitations in the superior oblique action with and just with the slight overaction of the inferior oblique, or slight, not much. Okay, I'll go now to the other eye. There is overaction, high overaction of the inferior rectus. That's it in the other eye.
Okay. Diagnosis?
With diagnosis is the right superior oblique palsy.
Wonderful. Wonderful. Well done. The third and last one.
Sir, can I try? Yes.
Please go ahead.
Okay, yes. This is a Hess chart and showing that the affected eye is the left eye, and there is a limitation of movement of all gazes except the lateral one. And on the other hand, the other eye, that the right eye, shows the overaction in all direction. So mostly it's the case of the left third nerve palsy.
Yes. Fantastic. So these are the three that are most likely to come in your exam. In my FICO, they had put a Duane retraction syndrome. That does not look like any of these three. But I don't expect that in an FRCS, they would keep something like that. That is not to say that it can't happen. If you have the time, in Pradeep Sharma's textbook, all of them are there. But if you don't have the time, just remember these three, and all of you have described it quite well, so it should not be a problem. Can somebody try and describe this 9-gaze photograph, please? And try and make a diagnosis?
Yes, sir. So
Please go.
it's a photograph showing picturing eyes in 9 gazes. The central square which shows that eye in the primary gaze seems to be slightly no, it's orthophoric, and
Ortho,
the
because Hirschberg
right
is
and the
center.
left gazes
Go ahead, go ahead.
are Hirschberg. In the dextro version and the levo version, the eyes, there is no abnormality. However, when the upper right showing dextro elevation shows the limitation of right eye in elevation. And similarly, in the levo elevation, there is a limitation of the left eye. Yes,
No.
the same eye.
This is the one thing that is a little different. In dextro elevation, there's limitation of the left eye elevation. And in levo
Yes,
elevation, there's limitation of the right eye elevation.
right eye elevation. Yes.
Got it?
So
You just switch the
alternative.
eye. You got it right, but you just switch the eye. So that just be very mindful. If I may suggest
Yeah.
a different way of describing that, may I?
Yes. Yes, sir. Please.
There's limitation of elevation of there's limitation of elevation in adduction of the left eye during dextro elevation, and there's limitation of elevation in adduction of the right eye in levo elevation. So when you say that
Yes.
limitation of elevation and adduction,
Yes.
you know, and the examiner knows that you know. So now, can
Okay.
you make a diagnosis for me?
Sir, because there is a limitation of elevation induction, most probably it goes towards the Brown syndrome.
Yes, wonderful, excellent.
So
So
it's a bilateral
please go ahead. Bilateral.
Brown syndrome.
Yes, yes, absolutely. So just remember this case, primary position ortho, all right? So Brown syndrome is characterized by absence of elevation in adduction, unaffected elevation in primary position and abduction. There may be normal or minimal overaction of the ipsilateral superior oblique. There's a positive forced duction test for the superior oblique. And there's frequent depression of eye in adduction, known as a downshoot in adduction. Now let's look at this. This is a different patient, also with Brown syndrome of the left eye. For this patient, in dextro version, there is a downshoot, okay? Because of superior oblique overaction. And now what happens when you have something like this? And I don't know whether you can appreciate, but in the primary gaze also, there's a mild hypotropia of that eye, the left eye. So this patient actually had 624 vision in the left eye because of strabismic amblyopia. So the first patient that you have described, if the vision is good in both eyes, you don't need to do anything because cosmetically this is not disfiguring. Vision is good. But here, primary gaze, there is a squint, there is a downshoot, there is strabismic amblyopia. So here you need to relieve the restriction. So you may do something known as a chicken suture. So you pass a non-absorbable suture through a particular width of the superior oblique, and then you cut in between the non-absorbable suture. So the two parts of the superior oblique move away from each other with a suture occupying the space in between. So that lengthens the superior oblique tendon and relieves the restriction. So this is a pre and post-op of that patient. I just showed you the pre-op photo in the previous slide, and this is a post-op photograph. This was performed by my teacher actually. Can somebody describe this?
Yes, sir. Okay.
Please go ahead.
In primary position, there is exotropia of the left eye.
Yes.
Okay, in dextro version, there is complete adduction for right and complete adduction for left, and dextro version and elevation. there is limited elevation for the right eye and also for the left eye. And in the down gaze, there are also limited, non-limited depression. So there is limited elevation just for the right and the left eye in the dextro version. In levo version, there is limited adduction for the right eye with complete abduction of the right. And in elevation in levo version, there is also limited elevation. And in depression, there is it is intact. No problem. Okay. So I can guess now that is a case of third nerve palsy.
Sorry?
Left third nerve palsy.
Sorry, I couldn't catch you. Could you mention the diagnosis again for me?
Left third nerve palsy.
Third nerve palsy. Third nerve. No. So this is not a case of third nerve palsy. I apologize if it's looking like that, but the elevation is not limited for either the left eye or the right eye. Elevation is normal. Not exactly. I'll come to that also, but there's no limitation of elevation. Okay. So when you look at the elevation just above the primary position photograph, there's a photograph of the elevation. So there's no limitation of elevation. You mentioned there's no limitation of depression. That is also correct. So if elevation and depression are not limited, it is unlikely to be a third nerve palsy. Okay. Now, what is there in addition to the exotropia is there is over elevation in adduction for the right and the left. Okay. I repeat, there is over elevation of adduction for the right and the left eye that you can see in dextro elevation and levo elevation. So for example, if you look at levo elevation, the left eye is looking up and out and the right eye is only looking up. So that is over elevation in adduction. So you have a case of exotropia with bilateral over elevation in adduction leading to a V pattern. Okay. So now I want to ask you, how will you manage this patient? Patient has a vision of 6/6 in both eyes and has come for squint correction procedure. How will you manage this patient?
So the problem is just V pattern. So I'll direct the inferior oblique.
No, yes.
Okay. If there is inferior oblique under action, I'll direct the inferior oblique. Or I'll act on the medial rectus. I'll do downward transposition for both medial recti.
Okay, so it's good, but you also need to take care of the exotropia. So what would you like to do for the exotropia?
I'd like to do medial rectus resection and the lateral rectus recession.
Okay. All right. So you're right about the exotropia part, lateral rectus recession with medial rectus resection. But when you have a pattern, V or A pattern with corresponding oblique overaction, you should treat the pattern by taking care of the oblique overaction. So if you have a V pattern and with inferior oblique overaction, you do a recession of the inferior oblique. If you have an A pattern and there is superior oblique overaction, you do a recession of the superior oblique. All right. If you do not have inferior oblique overaction and you have a V pattern. So for instance, here you clearly have over elevation and adduction. Let us say you don't get over elevation and adduction, but you get a V pattern. In that case, along with the resect procedure for the exotropia or the esotropia, you will also do a transposition. So just remember the mnemonic male, M-A-L-E. So the medial rectus is always transposed towards the apex of the pattern and the lateral rectus is always transposed towards the open end E. So in this case, if there was no inferior oblique overaction, you would end up transposing the recessed lateral rectus towards the open end, that is upward, and a resected medial rectus towards the apex, that is downward. That is how you would add on to correct the pattern strabismus. Now, what is the new?
Sir,
Sorry?
Can I ask a question?
Please ask.
In this patient, in the lipo version, there is limited adduction.
Yes.
In the right eye.
That's right. That's right. But actually, you know, I believe that the photo was not taken properly in this case. That's why I didn't mention it in detail. Because if you look at the photograph of your primary position and levo version, they're exactly the same. So either the photograph was not taken properly, or there may be a limitation of adduction in the right eye. Now, to confirm that, you should check the duction individually. For that, you may close the left eye and then check the movement. So often, then you will be able to see the full range of movement.
Okay.
Okay.
Then if this is a true limitation, can we put Dwayne in the differential diagnosis or not? I know there is no retraction, no up or down shoot, but can we put Dwayne in the Dwayne type 2?
You can. As a differential, you can put it.
Okay, thank you.
But I would always try to give the common differentials first.
Okay.
So what's the Newcastle score? Can anybody elaborate on that? The Newcastle score?
For exotropia treatment, how to diagnose the intermittent exotropia? There is a office, the clinic score and a home score.
Correct.
How long, how much time per percentage of time the baby get squint. And from that, we will get an idea whether to operate or we can do conservative treatment.
Okay, great. 1 second. I'll just start the presentation again. Can you see the presentation?
Yes, sir.
All right, wonderful. So the Newcastle score, like she mentioned, is used to quantify intermittent divergent squint or intermittent exotropia. You look at home control, clinic control for distance, and clinic control for near. So home control is you have to ask the parents whether squint or a monocular eye closure is noticed, if never noticed, or seen occasionally, that is less than 50% of the time for distance, seen frequently, that is more than 50% of the time for distance, and it is seen for distance and near. Now, why is monocular eye closure? This is because patients with intermittent exotropia, when they develop a decompensation of the foria, that is the eye drifts out, they develop diplopia because both eyes, when their eyes are aligned, they have fusion. So then when the eyes drift out, they develop diplopia. To counter that diplopia, they close one eye. This is also known as diplopia phobia. All right. Now, you also look at the clinic control for near and for distance. That is something that you will observe in the OPD on the cover test. So you look at whether the exotropia manifests only after the cover test and resumes fixation without a blink or a refixation. Or they blink or refixate themselves. They bring the eye straight after the cover test. or the exotropia manifests spontaneously without recovery. And this is evaluated for both distance and near. So we say that if the Newcastle score is more than 3, it indicates that surgery is required. If it's less than 3, you may observe the child or the patient. Can somebody describe this photograph?
Okay, sir, I will tell.
Please, please.
So this is a 9-gaze photograph of
Right.
a woman. In the primary gaze, the left eye is isotropic,
Correct.
and on the dextro, in the dextro version, both the eyes are moving normally, and in the levo version, the left eye doesn't abduct. Then on elevation, the left eye is a little bit um, inward. It's okay. On elevation, it's fine.
Yeah,
On
just make it normal.
depression,
Yeah, okay, go
a
ahead.
little is. And on depression, the left eye is more inward.
Okay.
Then on dextro elevation, it's fine. Both the eyes are symmetrically moving. And on again on levo elevation, the left eye doesn't go out and upward. Then on dextro depression, both eyes are moving normally. And on levo depression, the left eye doesn't move. There's limitation of the movement of the left eye, and right eye is okay, fine. So
Now, yeah,
most probably this is a case of sixth nerve palsy.
all right, wonderful. So, 65 years old female with sudden onset binocular diplopia since 1 month. She's a known diabetic with uncontrolled blood sugar levels. So often, if they give a stem like this, they will want to ask you whether you're going to do neuroimaging.
Most probably, as the patient is diabetic and has uncontrolled blood sugar levels, this could be because of microangiopathy, and the sixth nerve palsy cause could be because of microangiopathy.
Right.
So we can there are two opinions. Either we can do CT angio and or MRI to check, or we can just wait and get her blood sugar control done and wait and see the improvement.
For improvement, right, right. So with a stem like this, that is, it's quite evident that they're pointing you towards a microangiopathy. You can say that, I would like to observe and get systemic control, ensure systemic control for the blood sugar levels and check for improvement. The
Okay.
next question will be, let us say that it has gotten fixed, and how many months will pass before you decide to intervene for the strabismus? Need to pass. How many months after the strabismus set in, or how many months after the sixth nerve palsy happened, do you intervene for the squint?
So I'll give her full blood sugar control.
Correct.
And give the medical management for diplopia, and would like to wait for at least 6 months before I decide to go for the squint surgery.
Wonderful, wonderful. So a 7-year-old female child came with inward deviation. All right. Uncorrected visual acuity 612, right eye 6.9, left eye. CTC, retinoscopy value, right eye 3.5 with 0.75 cylinder, left eye 2.5 with 0.5 cylinder. Cover test shows 40 prism diopter base out deviation. What is the provisional diagnosis and your line of management?
Yes, sir, I can take it.
Please go ahead.
Okay, it's most probably a case of accommodative esotropia. I will prescribe for the patient the full cycloplegic error of refraction in her glasses and the follow-up after 1 month and remeasure the angle for far and for near. If the angle for far is fully corrected and the near is residual, then I will prescribe for the patient bifocal glasses its convergence excess. But if it's residual for the far and for the near, then the patient will need for surgery or botulinium toxin with her glasses.
Okay. So what you said about giving the full CTC refractive error is correct. Very good. So you mentioned executive bifocals, didn't you? So what is the role
Yes.
of executive bifocal exactly? Can I ask? Not in this case particularly, but in general, what is the role of executive bifocal in esotropia?
I know that it's prescribed for the cases of convergence excess, but I don't know the mechanism of action actually.
Right. So I would not mention executive bifocal here because that's not what I'm looking for. Because I've not given you the AC by A value. Okay. You can say that I check the AC by A value. If the AC by A value is more, then I will also give an executive bifocal, which would be a complete answer. But in this case, he just wants to know that you are going to give the full CTC. And let us say that the AC by A ratio is normal. I have not mentioned the near distance deviation. I have not mentioned the IPD, so you can't calculate it here. So this is a half stem, so to speak. Now, when you called after 1 month, I call after 2 months, but that's okay. So after 1 month, when the patient comes back, then you remeasure the strabismus. And if it reduces, let us say from 40, it becomes 25, then will you operate for 40 or will you operate for 25?
For 25.
No,
Yeah.
for the residual.
You will, yes, you will operate for the residual. Exactly. So that you answered correctly. So the role of the executive bifocal is when there is an increased AC by A ratio or there is a non-refractive accommodative esotropia. For the refractive component, you have to give the distance correction. That is the full CTC correction.
Yes.
So I'll just run through the definition of amblyopia and the classification. So it's a condition caused by unilateral or bilateral decrease of visual function caused by form vision deprivation and or abnormal binocular interaction that cannot be explained by a disorder of ocular media or visual pathways itself. So there's no organic cause anymore. In appropriate cases, it is reversible by therapeutic measures. Now the classification, the strabismic amblyopia, there is anisometropic amblyopia that can be anisohyperopic or anisomyopic. So hyperopic will be plus power inducing amblyopia, anisomyopic minus power. There is form vision deprivation amblyopia that includes stimulus deprivation amblyopia due to ptosis or cataract, and ametropic amblyopia, that is uncorrected bilateral high refractive error such as in bilateral aphakia. Then you also have meridional amblyopia, that is because of astigmatism. You have nystagmus related amblyopia and organic amblyopia. So I would disregard the organic amblyopia definition because it goes in the face of the actual definition of amblyopia where they say that there should be no organic cause, but this is mentioned in one of the standard textbooks of strabismus. So you leave that, but the others, if you're ever asked about amblyopia, you need to try and tell them about form vision deprivation, anisometropic, ametropic, meridional, and strabismic. So these 5 you must mention. The must read is Hest and diplopia charting, esotropia and exotropia, Duane's retraction syndrome, which I did not cover, the cover test, sensory motor evaluation of strabismus, amblyopia classification, recession and resection. Thank you. Any questions?
Sir, for the reading the surgical steps, best book is, do you suggest Pradeep Sharma or some other book?
Pradeep Sharma is good. Or if you can get are you speaking from India?
Yes, sir. I'm from Kerala.
Right. So there, you know Zia Chaudhary?
Yes, sir.
Zia Chaudhary, I had the old volume, so I read that during my residency. The chapter on strabismus surgeries is excellent because Zia Chaudhary herself is a pediatric ophthalmologist. So that is another source that I can suggest to you. my experience with reading strabismus from Kansky has not been fantastic, because when I was a resident, it was the 7th edition, which is not a great edition. The newer ones I think are better, but strabismus part I have not gone through. So my recommendation would be
Okay.
Pradeep Sharma or Zia Chaudhary. Zia Chaudhary is really comprehensive because it's written from the point of view of AIMS PG exam and DNB exam. So they are the two toughest PG exams. So it's quite comprehensive. So that you can read if you have the time.
Okay, sir. Thank you.
Sir, I have one question.
Please, please.
Yeah, so for like recession and resection,
Right.
according to the prism diopter of deviation, we just need to say that for the medial rectus recession resection, it will correct almost 2 prism diopter, and for the lateral rectus, is it 1? Sorry, will it be enough, or do we need to know more in detail about it?
I didn't understand the 2 and 1 part.
Sir, what I mean that if you need to, for example, if it is a 40 prism diopter esotropia,
Right.
so for the recession of the medial, how much medial rectal recession would be required, and how much 1 millimeter of recession will correct how much of the deviation?
So actually, surgeries on because the medial rectus is bulkier and shorter, so surgeries on the medial rectus have effect than surgeries on the lateral rectus. So approximately,
Okay.
I would say about 4 diopters is corrected when you operate on the medial rectus 1 mm, and 3 diopters when you operate on the lateral rectus.
Okay. Okay,
But
thank you so much.
yeah, and this also you will be able to find in Pradeep Sharma if you have the time. I can upload the
Please.
copy to the group.
Sir,
Okay,
please,
thank you.
I have a question, please.
Yes.
About differentiation between Brown syndrome and superior oblique palsy and inferior oblique palsy.
Superior oblique palsy, Brown syndrome, inferior oblique palsy. Okay. What is your question exactly?
Yes, how can we differentiate?
Okay, fine. All right. So the differential for Browns will not be superior oblique palsy, because superior oblique palsy will, it will never show absence of elevation in adduction.
Yes, but there is absence of depression also due to tucking of the superior oblique tendon, right?
No, it's not like that. So what will happen in superior oblique palsy is that your elevation in adduction will be normal because your inferior oblique is normal. That's one point. All right. The FDT in superior oblique palsy will be negative. In Brown syndrome, the FDT will be positive. All right. The third point is the primary position. Brown syndrome will either show you ortho or hypo. And superior oblique palsy will show you hyper because of unopposed action of the inferior oblique, which is an elevator. So these are the differences between Brown syndrome and superior oblique palsy. Now, between Brown syndrome and inferior oblique palsy, FDT is an important differentiator. So the FDT is positive for Brown syndrome and negative for inferior oblique palsy. But in terms of motility, they will be almost the same. Absence of elevation in adduction.
Dr. Prabhat, if we describe superior oblique palsy as limitation of adduction in depression, would
Depression in
that be
adduction.
correct?
Depression in adduction.
Right. Depression and adduction. Right. Thank you.
It's called the copying muscle, actually. When you look at, let's say that you're sitting with a friend and you're writing an exam, I don't know if you can see my eyes, but you look down like this to copy what he's writing. So that movement will go away. So superior oblique is also the copying muscle.
Right. Thank you.
Anything else?
Doctor, can I ask the question, please?
Please ask.
Is there any way to simplify the Park strap test? I can't keep it at all.
Sorry, could you repeat that? I couldn't quite grasp your entire question.
The 3 Park step test.
No, unfortunately, there is no simple way to the Parkes three-step test. You will read it for the exam. You will find your way to remember it, and you will forget about it the day after the exam. I really, I
Okay,
mean,
thank
I practice squint. It's my second specialty, but I practice squint and I read every time and I forget every time.
Okay.
Okay.
But if
Thank you.
you want, I can read about it and have a separate session for the Parkes three-step test. I don't have cases on Parkes three-step test, but I can discuss hypothetical scenarios. So let Dr. Kaushik know if that is something that everybody's interested in.
Okay.
Yeah.
Okay, thank you, sir. Thank you so
Right.
much.
Thank you, sir.
It was great to have this interaction, and I hope that everybody has benefited. Thank you. Thank you so much.
Thank you.
Bye. Bye. Take care. All the best. Yeah. Yeah.